Thank you, Wally, for setting the stage. And now I will bombard you with some data. So, as Wally mentioned at the end, the latest statement by the ACSM that includes reference to pleasure and displeasure was in 2011, the guidance for prescribing exercise. If I may take a moment to philosophize here for a second, it's hard to emphasize how important this is because the exercise prescription guidelines since the beginning, since 1975, have been traditionally dualistic. The best case scenario was that we had the chapters on physiology and there was a separate chapter on behavior. This is the first time in history, in a long, long time, where you begin to see a synthesis. You begin to see a convergence. The first time that a psychological variable like pleasure, displeasure, is measured as a way to regulate and monitor exercise intensity. So there's a philosophical undercurrent here that I think is important and should not be missed. So they said that exercise that is pleasant and enjoyable can improve adoption and adherence to prescribed exercise programs. So from a psychological theory standpoint, this whole line of thinking is based on an ancient idea called the hedonic theory of behavior or motivation. And it's really simple, probably seems too simple for how insightful and important and crucial it is. So it basically says that pleasure is an important determinant and regulator of behavior. Now, outside of exercise science, this is not a particularly controversial idea. So, for example, if I ask you, why do drug abusers abuse drugs, I think we can quickly agree that the pleasure that they derive from those drugs of abuse is probably a crucial factor in driving their abusive behavior. If I ask you why humans overeat, I think we can quickly agree that it's a two-factor process. One is what they call homeostatic, and the second is hedonic, right? In other words, we eat because we're hungry, but we also enjoy eating. I mean, there's nothing particularly controversial. Even in areas that have developed outside of the confines of psychology, like physical therapy, for example, physical therapists have developed this idea of kinesiophobia, that refers to patients with chronic pain, chronic back pain, or chronic fatigue. They know that they should be exercising. They know that exercise is something great for their condition. They don't do it in large numbers. The reason for that is that it hurts. And for a physical therapist who lives with the patients, understands the patients, observe their behavior, this is self-evident. In psychology, it appears that for a number of reasons we have great difficulty accepting this very straightforward and uncontroversial idea. So that's a topic for a different conversation, a different time. If you ask the participants themselves, interestingly enough, instead of just imposing your own ideas by administering questionnaires to them, the patients, through open-ended qualitative interviews, say, according to a review of that literature, fun and enjoyment were reported more often as predictors of participation and non-participation than perceived health benefits. So if you apply the hedonic theory idea to exercise behavior, it works out of something like this. You exercise. If you feel good, if you enjoy it, if you derive success experiences or a sense of pride from your accomplishments, you go back and do it again. On the other hand, if exercise makes you feel bad, exhausted, embarrassed, drained, fatigued, if you hate it, if you feel ashamed of your lack of accomplishment or your not fit enough physique, then you hate it and you don't do it again. So the general idea that we're working from is this. There's difficulty in appropriately regulating exercise intensity for a large segment of the population that is coming to us with a very low level of prior physical activity and cardiorespiratory endurance. the excessive intensity impacts affective responses, and then the affective responses translate to difference in adherence. Unfortunately, so far, we are still a developing line of research, so we don't have a study that has looked at the entire chain of events that I'm showing here. So we're going to take a look at evidence that we have, looking at the connections between these three factors, two at a time. So the first one is the relationship between intensity and adherence. The picture is a little convoluted because what happens is that even though you create two experimental arms and you dictate a certain level of intensity, it turns out that people just do the intensity that they want rather than the intensity that you've prescribed to them. So it becomes a little difficult to decipher what the impact of intensity is. So this first one comes from an old meta-analysis from '96 from Dishman and Buckworth, looking at the influence of exercise intensity on exercise participation. And you can see that if the program that you're promoting is a low-intensity program, practically that 50% figure means if you're essentially marketing walking, then the success is pretty good. But if you're marketing anything more intense than walking, then the effectiveness of that intervention drops. This is from an experimental trial with coronary heart patients. You can see the comparison was between 50% and 85% of VO2 max over 24 months. And the attendance rates begin to split at about the sixth month. And you begin to see the separation between the high-intensity, low-intensity group, always in favor of the lower-intensity group. This is another trial. This is a sedentary women exercise adherence trial. Again, a comparison between two intensity groups. The first 40 to 55 of heart rate reserve. The second 65 to 80% of heart rate reserve. And by the 18-month of follow-up, you see a 20% difference in retention. Yet another group from here in Florida a few years ago. 45 to 55 of heart rate reserve versus 65 to 75 of heart rate reserve. And as you can tell on the left, there's a significant difference in terms of the intensity groups. Interestingly enough, there is no significant difference in terms of the frequency groups, which also, by the way, meant total time commitment. Because if you do an exercise program more times per week, but the same duration each day, if you add more days, you add more total time commitment. There's a common line of thinking in our field that people really don't exercise because they don't have time, and this piece of evidence shows that in fact the time commitment when people start an exercise program, time commitment is sedentary, intensity is secondary, intensity might be primary. Moving on to the second connection, affective responses and adherence. This is a relatively new developing line of research. We still don't know how to do that type of research the right way. The methods are still developing, but there is some preliminary evidence. So this is from a group at Brown University. They tested a group of people entering an exercise trial. During the incremental test, when they crossed over to the moderate range of intensity, they gave them the feeling scale. They asked people how they felt. That one score at the beginning of the program significantly predicted physical activity participation 6 and 12 months later, as you can see there. The sample was relatively small, 37 people. So it was then repeated with a larger sample, 146 people. The results were essentially the same. The figures were slightly attenuated, but the basic pattern of findings remained. So if I find moderate intensity more pleasant, that translates to people choosing to do more physical activity 6 and 12 months later. That is an impressive finding for sure. We also have a study with adolescents, and I highlight this study because the measurement of physical activity was objective. It was not self-reported. It was based on accelerometers, and I don't have time to go through the exact numbers, but you can see that higher ratings of pleasure on the feeling scale were associated with more objectively assessed physical activity by the adolescents in the future. Now, this is the area that me and Dr. Bixby primarily work in, intensity, the relationship between intensity and affective responses. So, until the year 2000, there was really no clear evidence that intensity influences affective responses. With Steve Petruzzello, who's sitting right here, we published a review. We highlighted some methodological issues that should be taken care of before we continued this line of research. 10 years went by, and we published an update a couple of years ago. And now it's becoming clear that the more intense the exercise, the worse people feel. So on the left graph, you see the relationship between blood lactate accumulation and the percentage of people in a sample that report improvements on the feeling scale. And this comes from several different studies from different groups in different countries. So each of these dots is actually a sample from a different study. So you can see what the pattern is. When lactate accumulation increases, the percentage of people who say that they feel better decreases. And on the right-hand side, you see the relationship between lactate accumulation and the percentage of people reporting declines on the feeling scale. And as lactate accumulation increases, the number of people feeling worse decreases. So clearly there's a dose-response pattern here. Now, what we have focused on extensively, and you heard Dr. Bixby mention it, is something called the ventilatory threshold, an important metabolic marker. This is from a study that was published several years ago now. And it had 3 levels of intensity, below, at, and above the ventilatory threshold. These are the affective responses when the intensity was below the ventilatory threshold, just a very mild, non-statistically significant decline during the typical rebound that happens when exercise ends. People feel better, and then a slight decrease during recovery. This is intensity at the ventilatory threshold. You see that the decline during exercise was slightly larger, but still not statistically significant until the very end, and then the rebound again. But compare and contrast these patterns with a level of intensity that was just 10% of maximal capacity above the ventilatory threshold, and you will see that with every 3-minute increment, the feeling became worse and worse and worse and worse. Every comparison was statistically significant until the very end, and then again the rebound once exercise is done. Dr. Bixby mentioned that book from a certain famous trainer to the stars, and the strong assertion that people do not select exercise intensity that is intense enough, so they really need to be pushed. So that pushed my buttons, and I did a systematic review a few years ago. So what you're looking at is every study that has ever been done where people were allowed to self-select their intensity on the left, and then the average intensity for that study. And the range that is marked in blue, light blue, is the ACSM recommended range of oxygen uptake for the improvement and maintenance of cardiorespiratory fitness. And you can clearly see that in the vast majority of the cases, the intensity that people selected was well within what the ACSM recommends for the development and maintenance of fitness. The few exceptions were outside of that range for very specific reasons. So either people were specifically told to go slow, or the distances were very short, like some biomechanics studies where they just had to work for a few feet and so forth. So there are specific reasons why those are outside. But everything else, if people are told, select your own intensity, and it's clear that the context is for exercise, not to be measured, for some biomechanical pattern or something, then people select the appropriate intensity. Then we did a simulation study. We were interested in what happens when a chronically sedentary individual decides to start exercise and they're pushed by their personal trainer, just a little bit. So we found middle-aged, sedentary, but otherwise healthy women. We brought them into the lab, and we told them that you're going to have to walk on the treadmill for 20 minutes, and the control of intensity is entirely in your hands. Every 5 minutes, you can increase or decrease the speed of the treadmill. The incline was kept flat. So this is the percentage of VO2 that corresponds to their ventilatory threshold. And you will see that the women, not having done any exercise in a long, long time, minimum of 1 year, but we had women that hadn't exercised in 30 years. They experimented because the sensations from their body when the body exercises were completely unfamiliar to them. So they started slow, and then they did okay, and they started increasing and increasing and increasing. And only the comparison from the 15th to the 20th minute was not statistically significant, indicating that they had started to stabilize. So that's the level that they kind of liked. At the 15th minute, they chose 92% of the intensity of the ventilatory threshold. At the 20th minute, 98% of the intensity. And I can assure you that the intensity of the ventilatory threshold is plenty for improving cardiorespiratory fitness. In addition, this is an interesting finding because it replicates findings from endurance athletes, marathon runners, triathletes, and so forth. When you look at the intensity that they select for practice and competition, they also select intuitively the ventilatory threshold. They don't know what the ventilatory threshold is. They don't, they've never measured it. They don't know where it is. Intuitively, that's the intensity that feels right, and they know that they can maintain. If they go any higher, physiologically, there will be a drift, and they will max out. So that's the highest level of intensity that they can maintain. And it appears that the women intuitively also sense that and can do the same thing. Now, does that mean that we should all the time, for everybody, just let them roam free and not control their intensity? Unfortunately, no. And that's happy news for personal trainers because it allows a role for them. They have to be around because there are individual differences. There are individual differences for a variety of reasons. Some people go too slow to derive any benefits. Some people go too fast because perhaps they've been told no pain, no gain. So the majority of the people, as you can tell, converge towards 100% of the ventilatory threshold, but there's a wide spread at the end of the 20th minute, anywhere between 60% of the ventilatory threshold to 160% of the ventilatory threshold. So in those extreme cases, the personal trainer has to intervene. So this is an extension of that, of what I just mentioned. We added the second visit where the imaginary personal trainer set the intensity. And the intensity was set at 10% more than the intensity that the people had self-selected, but the people did not know that. So this is what happens in terms of intensity selection if people self-selected. The intensity at the end corresponded to 84% of heart rate max and 98% of the VO2 at VT. So 84% of heart rate max, I think you will agree, is pretty decent intensity. Now, if you push them 10% more than what they self-selected, this is what happens. Intensity goes to 91% of maximal heart rate. Now, I don't know when the last time was that you chose an intensity of 91% of your maximal heart rate, but that's pretty tough. It's not easy. And then clearly they exceeded the ventilatory threshold. The intensity was 118% of VO2 at VT. Now, more interesting to us, this is what happened to affective responses. This is what happened when they self-selected, steady and positive. This is what happened when they were pushed 10% higher, continuously declining. And what do you gain physiologically? Probably nothing. The only thing that happens here is that you send people home with a memory of exercise that was unpleasant. That's what you're doing. Now, a group of our colleagues extended that line of research. They asked women to exercise at a +3 on the feeling scale that corresponds to I feel good. And what happened was, as you can see, very similar to our data, the intensity was very, very close to the ventilatory threshold. That's the line that shows 100% of VO2 at VT. And then they said, now I want you to exercise at a +1. So an intensity that feels slightly less good. And what they did to make that happen was that they sped up. And they sped up to an intensity that exceeded the ventilatory threshold. So to summarize a little bit and put things in perspective, this is a graph that shows gas exchange. So you have oxygen uptake on the x-axis, and you have CO2 excretion on the y-axis. And you can see where the ventilatory threshold happens when the two regression lines begin to separate. That's the ventilatory threshold. So you can think of this continuum of exercise intensity as being divided in three ranges. One range that is below the ventilatory threshold, let's call that moderate intensity. Roughly, approximately, you can think of that as being close to 50 to 60% of VO2 max. It allows the maintenance of physiological steady state, so if people exercise in that range, they can keep going pretty much forever. They will quit of boredom way before they quit because of any metabolic reasons. And in that range, approximately 80% of individuals report either stable or increasing pleasure. And this is a graph that shows that. So this is 15 minutes of self-paced walk. If you really count the lines, 80% of the lines either stay the same or go up. The next range of intensity, we can call that heavy intensity. It extends from the ventilatory threshold to the respiratory compensation point, a second ventilatory threshold. Very roughly again, this is close to 75 to 85% of VO2 max. If you hang in there long enough, maybe you can regain physiological steady state, but most people quit way before they can restabilize and regain physiological steady state. And in that range is when you begin to see a difference between the people who like intense exercise and the people who dislike intense exercise. So you see a lot of variability. Some people reporting pleasure, some people reporting displeasure. So this is what this shows. This is cycling at 60% VO2 max. If you count the lines, it's approximately 45% of the lines go up, 45% of the lines go down, about 10% of the lines stay the same. And then we get to the end. We get to the highest level of intensity. Let's call that severe intensity. It extends from the respiratory compensation point of VO2 max. Here you cannot maintain physiological steady state, so all of your physiological indices, heart rate, VO2, lactate, catecholamines, increase continuously until you max out and you have to stop. 95 to 100% report decreases in pleasure. That remaining 5%, I think that that's social desirability. Because I think that 100% of people, it's just human nature, 100% of the people feel worse. And this is what this demonstrates, and this is that 5% that I was talking about. Okay. So to conclude, this is an actual person. This is an actual woman from one of our studies. I did not select her because she's special in some way. It's just an illustrative example. So the data that you were actually seeing represent an actual person. She's a real woman. Now let's look at the specific numbers. 41 years of age, 157 meters, 61 kilograms, which means BMI of 25. She's not obese. She's borderline overweight. But she's chronically sedentary, came to us after decades of sedentary living. And an important factor is her VO2 max, 17 ml per kg per minute. I don't know how familiar we are with those numbers, but when I was going to school, our exercise physiologist happened to mention that some severely deconditioned 70-year-olds sometimes have VO2 maxes in the teens. And when we heard that as new exercise science students, you could hear a collective, that's impossible. How can a human being live with a VO2 max below 20? We find middle-aged, 30-something, 40-something women in our studies with VO2 maxes in the teens regularly, all the time. And it doesn't surprise us. And other people find the same, and they report that in the literature. So if the VT is at 60% of that max, it means that the VT is at 10 milliliters per kg per minute. Basal metabolic rate, 1 med is 3.5. 10 milliliters per kilogram per minute is 2.85 meds. Let me translate that gibberish. These are activities that are 2.5 meds, so below that person's ventilatory threshold. Moving about indoors, an example of that is if you're preparing dinner and you're chopping the carrots on this side of the counter, and then you move that and you put it in, So that type of movement. Slow walking, less than 4 kilometers per hour, mild stretching, fishing but from a seated position, light dusting, washing dishes, placing dishes on shelves, that type of thing is below ventilatory threshold. Now you're going to see what above ventilatory threshold intensity is for this person. Slow walking or carrying grocery bags, waltzing, fishing from a standing position, cleaning windows, sweeping, mopping floor, washing the car. Those types of everyday activities can put a person like that who is screened to be judged metabolically healthy, remember, sedentary but healthy. These can put that person above ventilatory threshold. Many years ago, there was a discussion in the medical literature as to how we are supposed to prioritize chronic heart failure patients for immediate transplantation because death is imminent. So what signifies that that person basically has days to live? And the criterion that they came up with was a VO2 max of 14. And the woman in my example had a VO2 max of 17. So that's, if you're a personal trainer, you work with sedentary folks, that's a thought that I would like to leave you with and open it up for questions. Thank you. Thank you.